I mean, I guess I'll take it from the top. I think I've gone through these, the disclosures. I think this is material that you're more or less familiar with. So why don't we start with the learning objectives? So today we'll discuss the current clinical criteria for psychosis and neurodegeneration. We'll talk about what we know about biomarkers, and then we'll talk about treatment approaches, and hopefully that will be relevant to the work you do. So we know that psychosis exists in all forms of dementia, and the point prevalence is about 30 to 50%. It does occur in all forms of dementia, but it's more common in some forms, such as Parkinson's disease-related dementia and Lewy body dementia. There are two main symptoms, delusions and hallucinations, usually visual hallucinations. And when you become psychotic and you're demented, the prognosis is worse. So the disease progression is greater. There's greater caregiver burden. You're more likely to be in an institution. And there's increased progression to dementia when it's detected in the MBI phase. So even if you don't have signs of neurodegeneration, but you have psychosis and mild cognitive deficits, you're much more likely to progress to dementia over time. So this is what I talked about in terms of the prevalence figures. And the blue bar represents visual hallucinations. The red bar represents auditory hallucinations, and the orange bar represents delusions. And this is fairly classic for what you see in Alzheimer's disease, about 30% prevalence of the delusions, substantially less in terms of auditory hallucinations, and then visual hallucinations are more uncommon. Lewy body dementia, you can see that the prevalence rates for visual hallucinations are very high. They approach 60%. Less common auditory hallucinations, and then delusions around 50% of patients. PDD is somewhat similar. And then frontotemporal dementia, for reasons that we don't fully understand, the prevalence rates of these symptoms are lower. Delusions being probably the most prevalent. And then in vascular dementia, it's very comparable to what we see in Alzheimer's disease. So when you do see hallucinations, they're very commonly visual. And delusions that we see in dementia are usually very simple. Somebody took my brush. I can't find my brush. Someone took it. The person in the TV is someone I don't identify. You're not my brother. You're my father. Things of this nature. Complex. You don't see as much of the complex delusions or the first rank symptoms, ideas of reference, thought broadcasting, You don't tend to see those things. You can see misidentification of mirror or TV images. So someone may look in the mirror and think that that person is somebody else, or they may look on the TV and see that there's somebody there, and they may start talking to that person. So again, up to 30% of patients with AD experience psychosis at any point in time. But over 50% of people experience these symptoms in the course of their illness. And then again, as I talked about, the frequency in Lewy body dementia is very common. Some people would say in excess of 80% of patients in synuclein dementias. And it's mostly visual hallucinations. People will talk about seeing things that are frightening, like animals or shadows. And then in MBI, we don't see these symptoms very often in MCI. When they do emerge, they are associated with increased risk of disease progression. So if we look at psychosis and psychotic symptoms, about 68% of symptoms resolve within 12 weeks, whether you treat or don't treat. So that's an argument for maybe revisiting the use of antipsychotic medications in patients. But there's a high rate of relapse. So even if symptoms resolve over a 12-month period, 50% of patients will develop them again. And then there can be new symptoms that evolve over time, about 60% of patients. And then there's quite a large number, about probably a quarter of patients, where the symptoms are persistent for over 12 months. So, and I mentioned some of this, that there's greater cognitive and functional decline if you have psychosis than if you don't. So the hazard ratio is about 1.5, or risk ratio rather, relative risk is 1.5, relative to those who don't have psychosis, and cognitive decline relative risk of 1.41. And then again, institutionalization is more common. And you can understand that because patients who have psychosis oftentimes uh, may become more agitated, more aggressive, more combative, and this often leads to um, things like institutionalization. Um, so the relative risk being 1.6. So mortality, uh, certainly patients with psychosis have an elevated risk of mortality. If you look at, and that's even if we exclude patients on antipsychotic medication. So if you take patients with dementia without psychosis versus those with psychosis will die more quickly, and that's exacerbated when we put them on antipsychotic medications. And then there's quality of life issues. So when you're psychotic, delusional, it has a significant impact on quality of life, really not just for the patient, but for the caregiver as well, because they may not know how to deal with the patient, or they may be given medications, but the medications may not work, etc. So we do have new criteria, new research criteria, new clinical criteria for psychosis and neurodegeneration. This is a research framework that had the pleasure of working on with Sandra Ishmael. We developed these criteria in 2020, and the impetus really for the criteria was, or new criteria. The previous criteria, published criteria, had been published in I think 2000. Was this notion that you can have symptoms even before onset of neurodegeneration. So you don't necessarily have to have a diagnosis of dementia. And now we can diagnose neurodegeneration even in the absence of clinical symptoms based on imaging and biomarker findings. So in our new research framework, we acknowledge the disease stage, are the symptoms preclinical, prodromal, or in the dementia phase. Uh, we note whether they're delusions and hallucinations, and we make a distinction between persecutory delusions, which are probably much more common, and misidentification delusions, which are probably rarer, but are very, very specific for dementia. If you see a misidentification delusion, you're probably dealing with a dementia syndrome. And then exclusions, we actually, in the research framework, excluded patients that were affective or had affective or agitation states. And again, we gave a time frame of 4 weeks, and noted whether symptoms were fluctuating or persistent. I think that that's an important distinction. Persistent symptoms obviously are much more challenging and problematic. We also have new clinical criteria now for dementia-related psychosis. These were published by the IPA, the International Psychogeriatric Association, and it was an effort led by Jeff Cummings and Mary Sano. And if you read through the criteria, what they do, which is useful, is they provide examples of common symptoms, and they acknowledge that these symptoms may occur across a whole spectrum of etiologies, neurodegenerative etiologies, so Huntington's disease, HIV-related neurocognitive disorder, traumatic brain injury. All of these disorders may have an association with psychosis, so it's not limited to one form of neurodegeneration. There's still the requirement for the symptoms to be present for 1 month intermittently, if not persistently, and there has to be an impact on function. And usually that's above and beyond what the dementia causes. So dementia causes functional impairment, but in order for one to have a dementia-related psychosis, there has to be psychosis that then induces further functional impairment. And in this particular iteration, they acknowledge that patients with psychosis can have agitation and depression, but they didn't think those were exclusionary. So this is a bit of a complicated slide, but it gives you a little bit of a sense of the complexity of trying to figure out what the mechanisms of these symptoms are. So, so this is a conceptual model. It was published in a Nature paper done, I think, fairly recently, 2022. And what you see here are, contributing factors that these symptoms exist across the cognitive spectrum. And that there can be many contributing factors. We're just starting to understand the role played by genes, AD risk genes. For example, ApoE4, there's some data emerging there. And there's some genome-wide association studies and other studies, polygenic risk score studies, that have looked at the issue of neuropsychiatric symptoms and found some interesting findings. There's epigenetics and transcriptomics, which are kind of complicated concepts, but again, they've looked at things like methylation and other factors in inducing these symptoms. And then there's the role of comorbid symptoms. Um, and I think that's one of the problems when we deal with try to study these symptoms is that they don't exist in a vacuum. Oftentimes, people are agitated, or they're depressed, or they're both. And how do we distinguish one from another? We know that medical infections and unmet needs of patients can play a role here. And then, finally, we know that there are circuitry issues involving default mode networks, frontal lobe, tau pathology, phosphorylated tau in particular, white matter disease, allergic tone. So there are all multiple mechanisms that may be at work. There probably isn't a single mechanism. Rather, there's probably a multitude of mechanisms. We do know certain things, though, that phosphorylated tau does play an important role in the development of dementia-related psychosis. So it's important to be mindful of that. There's also TDP-43, and then PET imaging, which has shown diminished flow to the frontal and temporal lobes. There's some theories that there are asymmetric findings in the brains of patients who are psychotic and demented, that they're more likely to be right-sided abnormalities or accelerated volume loss in the frontal and temporal lobes. And then PET studies show decreased dopamine uptake in the striatum. White matter changes. We don't really understand the contribution. And then the default mode network is also brain networks play an important role. This is a study published by Byron Crease in 2023, fairly recently. And so what it shows, the patients who are, I guess, MBI without psychosis versus MBI. The blue line is MBI with psychosis. The yellow line is MBI minus psychosis. And you can see over time, this is conversion rates to dementia. And you can see that it's much higher amongst the MBI cohort. And actually, in the presence of ApoE4, it's much more accelerated. So it suggests that ApoE4 is playing some kind of mediating role here. Similarly, if you look at patients that have sort of very late onset schizophrenia-like psychosis, and look at hazard ratios over time in terms of rates of conversion to dementia, what you see is that the years from onset of symptoms to onset of dementia, that there's a strong association in the first year after symptoms develop with a diagnosis of dementia. And that trickles down as time goes on and progresses. So again, biomarkers, our group has done a lot of work looking at female ApoE4 homozygotes. This was based on a neuropathologic study. And we found that those that had Lewy body pathology, and if you're a female ApoE4 homozygote, you're much more likely to express psychosis compared to males or those without Lewy body pathology. And again, this was an effect that seemed limited to female homozygotes, and only those that had coexistent Alzheimer's disease and Lewy body pathology. We haven't been able to replicate it in a clinical cohort yet, but it suggests that sex and zygosity, being female homozygote, might and having coexistent Lewy body pathology might make you more prone to becoming psychotic. There have been many other studies that have looked at ApoE4 and shown an association. This is talking about precision medicine, a number of studies that have been done in very, very large cohorts, published in a variety of journals: Translational Psychiatry, Alzheimer's and Dementia, neurobiology of aging. This is a large cohort study. A lot of this work has been done by Rob Sweet out of Pittsburgh, over 10,000 patients. And what they found, interestingly enough, is that psychosis in AD was correlated with depressive symptoms. In other words, there were twice as many people with AD and psychosis and an affective syndrome, just AD and psychosis, based on a number of the genomic studies they did. So genetic overlap suggests may give keys about more precision approaches for these phenotypes with the potential treatment implications. So when we look at psychosis, we see psychosis, but in fact, maybe it's not just psychosis. Maybe it's, psychosis. And there's another subgroup of psychosis with an affective syndrome or an agitated syndrome. And maybe these are different phenotypes that have different genetic determinants. All of this is very complicated, but we're starting to unravel this now that we have access to some of these tools that we never had access to before. Non-pharmacologic interventions, psychosocial interventions are crucial in all patients with behavioral symptoms, in particular amongst patients with psychosis. And they and I don't know to what extent they're fully utilized. This was a study done in the UK with the withheld, which without WHELD. It's a brief psychosocial intervention. It really involves doing some activities and engaging in some interaction with the patient for, I think, an hour, 3 times a week, something like that. But it's manualized, it's very specific. So they applied this intervention to one group, and then they applied usual treatment to another group. And they found that there were improvements in apathy, agitation, and quality of life amongst the patients who were psychotic, but the psychosis itself didn't change. Person-centered training, again, and the value of this approach is it incorporates not only a behavioral approach, but also an antipsychotic med review and brief psychosocial therapy. So there have been, Delphi processes where you interview physicians, you ask what's helpful in psychosis. So adapting cognitive therapy approaches, family interventions, and then doing personalized activities or environmental sensory programs. One of the problems is that a lot of the interventions are very individualized and not evidence-based. They should be protocolized, they should be evidence-based, similar to what we do with pharmacotherapy. And Clive Ballard and Joanne McDermott in UK have done a really good job of doing this. So this is a study that I referred you to. They used this behavioral intervention. These were patients in long-term care, 163 of them. 76 administered this psychosocial intervention. 87 had treatment as usual. And what you see is that the subgroup, there was really no impact on psychosis, but fairly, there was a significant impact on some of these other symptoms. Agitation and apathy responded well, and quality of life as well. So, I mean, some of the other things that we can do, and I always recommend we do, are, to optimize things like hearing loss and vision loss. Someone can't see and they can't hear, um, they're not going to be, we're not going to be able to do. They're much more prone to becoming psychotic. So very important to optimize those deficits, reducing isolation, encouraging social engagement. Again, pairing some of the interventions, the behavioral interventions, with med reviews so that you look at what meds are being used. Are they on 4 or 5 different medications that really aren't doing anything? All of that's important. There is a tendency in long-term care for medications to be piled on and then not deprescribed. So brief psychosocial therapy, that's part of the behavioral intervention I alluded to. Plan enjoyable activities with social interactions for each resident about 3 times per week. And it's very manualized, and you train the caregivers to administer this, and it can be quite helpful and effective. So what do we know about drugs, drug therapies? So if we look at the meta-analyses of off-label treatments, essentially all treatments are off-label because we don't have an approved treatment. So risperidone, aripiprazole, olanzapine, if we look at what they do, the benefits are small, in terms of psychosis relative to placebo. Quetiapine really, based on the meta-analysis, didn't show any appreciable benefits, and maybe that's because it's not a potent enough antipsychotic. Hard to know. But even the effects with the others were quite minimal. If you look at U.S. claims data, patients who had dementia-related psychosis, 75% of them were treated with either valproic acid. You could argue it's not really an antipsychotic, um, or an antipsychotic, and 80% received a low dose. Um, so maybe, again, we need to start looking at dosing properly. There's a tendency, again, to try one. If it doesn't work, move to another. And 65% switched or stopped meds over a 2-year period. So that tells you that, maybe the medications aren't as effective as we think. Citalopram, it looked at effects on NPI domains at week 9, and it did. There's some evidence actually, and I use it quite a bit myself, in the long-term care sector. Significant reductions in the prevalence of delusions and severity of hallucinations over time. So some good benefits there. Okay, so if we look at this is a study, the DART study. I don't know if you guys are familiar with this, but they looked at survival rates of patients on placebo versus on an antipsychotic over time. And unfortunately, as I alluded to before, is that your survival on placebos is greater than your survival on drug. And this seems to persist over time. So rates maybe go down a little bit over time. But again, on placebo, at 24 months, it's 71% versus on antipsychotic, it's 46%, which is pretty substantial. And then at 36 months, I think this might be months, might be weeks, to see if it's, I think it may be weeks actually, 59% on placebo and 30% on an antipsychotic. And then at 42 uh, weeks, 53% on placebo and 26% on an antipsychotic. This is just a reminder of cholinesterase inhibitors, that they actually can have an important effect in improving psychosis, and specifically in terms of delaying emergence of symptoms. So these are NPI scores, and this is donepezil, and they looked at placebo, 3 milligram, 5 milligram, 10 milligram, and you can see that scores improved over time with higher doses. And then similarly, there was reduction in NPI symptoms, again on higher doses of medication over time. So, and one of the challenges that we often face is what to use in patients who have Parkinson's disease-related dementia or Lewy body dementia. And there is a new drug available. I don't know if you've heard of it, although it's not available here in Canada, to my knowledge. It's pimavanserin. It's a 5-HT2A inverse agonist. And it's shown impressive data over placebo in terms of treating psychosis, and really no appreciable increase in the motor side effects. So it's been approved for psychosis in the context of PDD, but really not in terms of Alzheimer's disease. There was an effect at 6 weeks for Alzheimer's, but no effect over placebo at 12 weeks, so it was abandoned. There are future studies ongoing. And then, studied in patients with dementia-related psychosis, looked at patients who had a 30% reduction in symptoms, the randomized active or drug placebo, and patients who were on active drug were more likely to have a sustained response. And this is just a diagram of what I've been talking about. This is pimavanserin, and this is the placebo drug, and this is the percentage of events. And you can see in dementia-related psychosis, the effects are pretty good. But when you sort of divide that into PDD versus AD related, it's pretty clear that it's driven to a large degree by the PDD group, and that these other groups really, it's not as impactful. Um, and I think this is my last slide, but Xanomeline is a drug that has been sort of repurposed now for patients with schizophrenia. They've added trospium to it to counteract the cholinergic effects. And it's now being prescribed as well, it just got FDA approval in late September as a treatment for schizophrenia. It's a muscarinic agonist, and the initial study was back in 1997, and it showed impressive effects on psychosis, but because it didn't really have significant effects on dementia, it was abandoned. And so you can sort of see here the dosing placebo, 75, 150, 225, and you can see the reduction, the number of patients whose symptoms stopped during this intent to treat analysis, a substantial effect on hallucinations, compulsiveness, delusions, suspiciousness, focal outbursts, mood swings, unsafe use of appliances. I'm not sure what that refers to, but you can see that the effect on delusions and hallucinations is quite substantial. And that symptoms can start to resolve. The effects can begin about 2 to 3 weeks after initiation of treatment for those patients exhibiting symptoms at baseline. So there's a new IPA initiative. I am part of it. There are a number of other Canadians as well. Crystal Lenkto's involved with this as well. And it's an exciting initiative to develop new approaches for the management of behavioral changes observed in patients with neurodegenerative disorders. And stay tuned. We should have more on that in the coming months, in the coming year. So I think that's it. Here's my summary slide. Summary. So just to summarize, psychotic symptoms exist across this spectrum, this neurodegenerative spectrum. We know that they're associated with the worst prognosis. And when present in patients who are clinically or cognitively normal, they hasten conversion to dementia. We have new clinical and research framework that we can use. There's some emerging areas of interest in terms of phosphorylated tau, Lewy bodies, ApoE4. There's some very exciting things happening in genomics in the field. Good evidence for non-pharmacological approaches, but the importance of those approaches being manualized, and some evidence that the drugs may work, although they may work on things other than psychosis, such as agitation, and a bit of a caution because of the elevated mortality risk. And then some exciting developments in the field in terms of new therapies. We have 5-HT2A inverse agonists and muscarinic agonists on the horizon that may provide some appreciable benefits. Although I should emphasize the xanomeline is not yet approved for AD-related psychosis. I think studies have just been launched. And that's it. Thank you.
All right. Thank you very much, Dr. Fischer. Um, so if you're able to stay on for a couple of minutes,
Yep.
if anyone has any specific questions for Dr. Fischer, um, please put them into the chat. Stacy Hatch is asking, so first of all, so happy to hear about McDermott and Ballard's research into psychosocial interventions. What do you think would be barriers to applying their findings in a Canadian context?
That's a very good question. I mean, I do consult to long-term care homes, and I think one of and then obviously the hospital setting. I think one of the well, there's a couple of barriers, but I think one of the main barriers is lack of staffing, right? I think we just don't have the staff. I'd be interested to speak to them and just see how they were able to implement this, because maybe the situation in the UK is different than here in Canada. But in Canada, obviously, there are oftentimes homes are understaffed, and they may not have the staffing required to carry something like this out. So although they most homes do have behavioral staff that are now assigned, and so maybe part of it is just the willingness to take something like this on, and Certainly, I think, although I've seen a shift in the long-term care sector myself, there's certainly, the homes that I consult to, um, they're most of the homes are eager to look at sort of non-drug approaches to therapies and treatment. So, I think there's certainly more on that horizon that could be done. I think part of it though is related to staffing and finances. Sadly, yeah.
All right, thank you. So Una Hayes is asking, can you speak about how to manage someone who is responding to risperidone slash citalopram for psychotic symptoms prescribed for assumed AD who develops Parkinsonian features?
Yeah, that's a challenge, and there's really not much you can do about that. Obviously, in that context, it would be the risperidone; it wouldn't be the citalopram. So you'd have to. An EPS is a kind of a deal breaker. If someone has EPS, you have two choices. You can reduce the medication and see if it stops, or you can simply discontinue the medication. I don't believe in prescribing benztropine because it just causes more cognitive impairment. So I think you'd have probably have no choice in that context. I would reduce it, see if the symptom resolves. If it does not, then you have no choice but to stop it, and then you can sort of explore what other options you can use. For example, like obviously Seroquel doesn't have as much, but it's not very effective as an antipsychotic. So
Okay,
yeah.
thank you. And in case anyone else is going to be putting something into the chat, I'm just going to ask a question while we're waiting. Just to clarify, in your slide deck, you referenced MBI a couple of times.
Hmm.
And I was wondering if you could clarify that.
Yeah, it's a good question. So MBI is mild behavioral impairment, and it's a term that really refers to patients who don't have appreciable cognitive symptoms, but do have behavioral symptoms. And they can be subtle behavioral symptoms. So subtle changes in personality or motivation or mood that maybe emerge either with very mild cognitive and findings, or even in the absence of cognitive findings. That's a subgroup of patients, and we know that those patients are much more likely to go on to progress to dementia. Zainer Ishmael and the iStart group really started or pioneered that concept.
Okay. Well, I don't see other questions right now in the chat. So again, I want to thank you so much, Dr. Fisher, for the great talk
Thank you.
and your time. And at this point, what we're going to do is we'll say goodbye, and instead we're going to move on to the case presentation.